up, guys? It's Khadija here with Nursekayexplains, and today I will be discussing how to survive your ICU residency program. So, some of the topics I will be discussing is specific to ICU. However, majority of the things I will be discussing today is actually applicable to any residency program you're doing. So, number one, this is specific to ICU, telemetry, ER. Any kind of residency where you're doing any kind of cardiac monitoring, and that is you have to know your cardiac arrhythmias, y'all. And I say this is number one because a lot of ICU residency programs, or the programs I just listed, they actually require you to pass a cardiac arrhythmia test or EKG test prior to starting your program. I remember for myself, we had, I believe, 2 attempts to pass the test, but we had to get 100% on our lethal arrhythmias, and then overall you just had to get 80% in all the other areas. But your lethal arrhythmias, you had to get 100%. You don't want to get, accepted into the program and have to get kicked out because you fail, the EKG test. A lot of times we depend on our cardiac monitors, but you cannot depend on that. You have to know it. A lot of times, like for example, if your patient has a peak T wave, your monitor might be reading that as like ST elevation, or if your patient's like moving around in the bed, or if there's some artifact going on, they might read it as VTAC. And this is something that you're just going to have to know for the rest of your life, while you're working, at least at the bedside. I did discuss in a previous video a free resource called skillstat.com where you can practice your cardiac arrhythmias. They have 3 different simulators. They closely simulate real cardiac arrhythmias. You have to know how to intervene if you see your patient going into 3rd-degree heart block, or your patient going into VTAC, V-field, or what have you. Number 2 is having a preceptor that meshes well with you. So a lot of times we don't choose our preceptor. Our manager chooses our preceptor, and a lot of times they don't know us. So they don't know our learning styles or who we work well with. But the thing is, you have to advocate for yourself if your preceptor is not for you. Some people just don't mesh well. The personalities don't mesh well. And if you feel like that you are not learning with that particular preceptor, if you feel like they are, for example, I hate to say this, but if they are lazy, or if they get frustrated anytime you ask a question, or anything like that that makes you feel uncomfortable or makes you feel like there's a hindrance in your learning, you definitely need to reach out to your management, to your charge nurse, and let them know. It will be a shame on you if you do not advocate for yourself. I know a lot of times, we'll get to this later about the cliques and things like that, and a lot of times, we're going into a new atmosphere, a new place, meeting new people, and we don't want to, be a burden or be an issue, so we get afraid to speak up. But, a lot of these residency programs are, 8 weeks or 12 weeks. And you don't want to be in a situation where you are with somebody that for one, you're not learning from, 2, you feel uncomfortable around to even ask questions. Because if you do not know what you're doing, you will make mistakes. If you want to assume things, you will make mistakes. And that's going into number 3, y'all. Do not assume. Do not be afraid to ask questions. And that's down the board, whether it's your preceptor, whether it's a doctor, a manager, a charge nurse. A lot of times people make mistakes because they do not ask questions, because they are afraid of how they will look. They are afraid to be a burden to someone else. But at the end of the day, that patient's life is on the line. Are you going to kill somebody because you're too afraid to, ask a doctor what he said when there's a code and, everybody's rushing, it's loud, alarms is going off, people are on edge, and you didn't hear what he said, but you're just going to do what you want to do and, push something that he didn't say push, and then, things get worse. You don't want to do that. You don't want to be the person that's pushing a paralytic before a sedative. Mistakes like that happen all the time. A lot of times because people are too afraid to voice that they didn't hear something, or to voice that they don't understand something, or even voice a question that they may have. There's so many examples I can give. Like there's people who have inserted injections with blunt needles because they're too afraid to ask a question, or they just assume that they know it. You don't want to be a know-it-all, you know what I mean? You don't want to, like I said, you don't want to assume that you know it all. You definitely want to be, and that's why it goes back to number 2 when I discussed being with the preceptor that you feel comfortable around. Because if you feel comfortable around a certain person, you're not going to be afraid to ask questions. You're not going to be afraid to, be vulnerable and express how you feel. Because a lot of times in these residency programs, it might not be just clinical. It might be, just stress or mental that, you may be going through. So that's good to have that support, and that's what your preceptor is for. And that's why it's important to advocate for yourself, ask questions, talk to your preceptor, talk to your charge nurse. And even if, say, for instance, I remember my program, there was a certain amount of preceptors that we had on the unit, and my group was like pretty big. I believe it was like 12 or 14 of us. So even if you're afraid to, maybe you have to move to night shift, just do what you have to do, or day shift, or what have you. Do what you have to do to get with somebody that will be helpful for you at the end of the day. Because not only is that patient's life on the line, but your license is on the line as well. So be very mindful of that. Number 4 is bedside report. A lot of these things I'm discussing, you want to get into the habit of them. Like I said, it takes 21 days to build a habit. And some things you're going to just go with the flow of what your preceptor taught you. And you want to, apply these to you when you go on your own. And a lot of times I know we don't do bedside report, or we stand outside the room. And that's, if that's how your uniculture is, but best practice is bedside report. But when I say that, I definitely mean going inside the room, if nothing else, to make sure your lines are secure, make sure your formulas are going at the right rate, make sure that, your IV is hooked up and that it's going at the correct rate and the correct weight for that patient, okay? You would not believe how many times I've gone into a room and seen that the, medication was programmed in wrong and the rate was wrong, or the patient's weight was not correct because they come up from the ER on, y'all know how the ER do. No shame, no. Also, you have to think about it. Now, I'm a day shift person, okay? And I used to work night shifts. However, majority, literally 90% of my time being a nurse, I worked the day shifts. And you have to think about it. So on night shift, they give a bath. Most of the time, it's around 4 or 5 o'clock in the morning, right? And then they disconnect sometimes that tubing, the IV tubing, to put their new gown on. I've seen several times where lines were not secure. So you think a medication is infusing, and it might be on there a little bit, but not all the way. So some of the medication is leaking out, or it's not going at all. It's actually not secure at all. So imagine if a patient's on a paralytic or on sedation or on, a vasopressor, and they're not getting all the medication or none at all, how detrimental that can be. There's been times, and this is, anybody can tell you this, probably every nurse has experienced this in their career, where they come in and the tube feeding isn't infusing because valve is on off instead of on. So you look underneath that gown when you do your assessment, or when you do a bedside report, and you see that there's tube feeding all over the bed. And then also, like I said, the main things though is to make sure that those lines are secure. And there's been many times where I did the eye trace, where I traced to make sure it's secure, but I'm not really checking. So you really have to check that, because you will learn the hard way. You don't want somebody to self-extubate. You don't want somebody to go into lethal rhythm, or, their blood pressure keeps dropping, right? Their blood pressure keeps, you're like, why are they blood pressure, not going up? What I'm saying? I keep on going up on the lever, but you have to be mindful of those things. So I've experienced that not only with some of my patients, but with other people's patients. If a code happens, we're going in and we're trying to figure out what's going on. And then if I'm the person that's doing meds and I see there's leakage all over their gown for their line wasn't secure. Or, I'll go in to give medication, the line's not secure. So it happens more often than we know. So you can avoid a lot of things if you do that. Another thing is bedside rounding or multidisciplinary rounds. So like I said, I'm a day shift person. Each facility is different. And a lot of large facilities is typically, like I said, multidisciplinary. So you will have your physical therapist there, your pharmacist, your intensivist, the charge nurse, yourself. Sometimes they allow, the patient family to be in on it, the case manager or social worker as well. And basically, we're talking about the patient. Some facilities, if you're at a teaching hospital, I did my residency at a teaching hospital, so we had a 40-bed ICU. So if you worked on hallways A or B, then you would know that the resident will give the report. However, if you worked on hallway C and D, the nurse led the report, because that just means that there's no residents on that side. However, a lot of facilities who do not have residents, the nurse will lead the report. And I hate to toot my own horn, but the number one compliment I get from physicians is how great my reports are. In which I don't understand that. Shout out to Mark, my preceptor back when I was in the ICU residency, because I just feel like I just basically do a thorough report how I would do my regular bedside report with a nurse. But yeah, so the way I do it is, and say for instance, if the patient had a significant event that happened, overnight, I will state that. Like this patient was asynchronous with the vent all night. They had to bag him. They had a lavage or what have you, But then I go into head to toe. So I would start with neuro, and then I go into cardiac, respiratory, GI, GU, skin, IVs, and I talk about my drips as they relate to the system. So when I go over sedation, or when I go over neuro, I'm talking about sedation that they're on. So I'm talking about if they're on fentanyl, Versed, are they on a, and if when I go into a respiratory, if they're on a paralytic, I'll discuss that, or Flowland, anything like that. If I'm talking about cardiac, then I will incorporate any cardiac drips that they are on, like vasopressors, amio, anything. If they are, when I get into the GI, if they're there for GI bleed, I'll incorporate, they're on 8 milligrams an hour of protonics. They've been on this for 24 hours and what have you. Like, you talking about they're on a Lasix drip, or whatever. So I do go from head to toe. So, and then for me, it's easiest by using this report sheet. This is the actual report sheet that I use. So it's very simple. It's compact. I can fold it. I can put it in one pocket. No shade to anybody who uses like the clipboards or the foldable clipboards. But for me, this is much easier for me to do it this way, because as I'm going over my patient, I can just quickly look down, don't have to scramble through a lot of different papers, don't have to flip through a clipboard, and I can just look down, and both of my patients fit on one page, because like typically in ICU, we get 2 patients. The thing is to get over the fear of, talking to your team. A lot of times when we have a lot of fear, we make mistakes, but the way to pick off pieces of that fear is to have confidence. And what builds confidence is knowledge and, feeling like you know what you're doing and knowing what you're talking about. And any kind of process or resource that helps you do that is great. The thing is to help decrease the fear of talking to doctors and improving your confidence is by utilizing SBAR. I know we learned this in school, but SBAR absolutely works. If you are doing SBAR when you communicate with a physician, whether it's face-to-face or over the phone, they will get the information they need to make a great recommendation for you. Hopefully, no one is in a situation where they are being bullied or being talked to, wrong by physicians. I know that it used to be a culture with nurses having to deal with that a lot. But, in the times we're in now, we see that less often. But it is still out there. But a lot of times, if you are telling a doctor what they need to know, they will be more receptive to you. If you call a doctor and you're like all over the place and not defending any kind of negative behavior, but if you're all over the place, then they will get frustrated. You got to think about it. Even if whether you're doing a telemetry unit or working in the ICU, a lot of these doctors have patients like all over the hospitals. So if you call and you're not giving the right information in a good flow, it'll be hard for them to give you a good recommendation. They're going to be frustrated and they're going to say, call me back, or they're going to have an attitude, or they're going to deem you as incompetent or think you're incompetent. When I'm calling a physician, I would just be like, hey, this is Khadija calling from so-and-so. A lot of places in a smaller hospital, think about it, these physician works at several different facilities. So calling from so-and-so, I'm calling because of this. This is what was going on beforehand. This is what's going on now. This is what I've done thus far. It's not working. This is what I recommend, but what do you think? You know what I'm saying? That's how you do SBAR. Another thing I want to talk about is Cliques. So, unfortunately, a lot of students that I mentor or coach, they talk about the Cliques, and how it is very negative atmosphere that they're feeling on the unit that they're on. Because it's like the mean girl syndrome is going on their unit, or A lot of people going out to breakfast and not getting invited, or just being mean for no reason. My advice to that is, for one, if you hear somebody talking about another individual, like if you're in the break room or in the elevator, if y'all transporting somebody or what have you, do not say nothing. Like, don't feel peer pressured into talking about that person. So if somebody comes into the break room and you're trying to eat and they're like talking about an incident that happened with, I don't know, Nurse A, like, I just be like, just nod, okay, and keep it moving. Don't engage in the conversation. Don't be like, oh, and when I had that patient, they did this to me. Like, that can cause a lot of drama that you don't want to be in at all. So it's best to try to avoid any kind of negative energy. You are there to work. You are there to make your money. You are there to keep people alive. You are there to make sure that your patients are safe and to make sure your license is protected at all times. Try not to engage into the petty drama at all, if possible. Like, even if you're out on lunch outside of the hospital, if you get invited with one of your coworkers, just not. Okay, like, you don't want nobody going back and saying nothing, whether it's 3 months from now, 6 months from now, or what have you. I'm telling you, do not get involved into the clique stuff. That's my last piece of advice, is to stay motivated. And you can do that through mentorship, finding a mentor, or like I said, if you get close with your preceptor, do things to make you, motivated, write it to journaling. I even have like a nursing vision board kit that I created, and a lot of people say like that helps them. They keep it on their wall. You can use this whether you're in nursing school or whether you are doing a nurse residency program. If you just have goals, just keep your mind on your goals and what you want moving forward, whether it's the family, the lifestyle, just being like progressing in your career to be like a nurse practitioner or a CRNA. Whatever goals that you have, just stay motivated and keep in a positive mindset to do that. So if, like I said, I have the links below for the vision board to help you stay motivated. I also have the link below for the report sheets, as well as the videos when I talk about skillside.com to help you learn your cardiac arrhythmias. If you have any specific questions or any struggles that you're going through in your residency program, or if your ICU or your facility don't do a residency and you're just on training, just hit me up on my social media. You can DM me or send me an email. I have gotten a lot of emails for people struggling through the residency, and a lot of it, is stuff that not necessarily have to do with what I talked about, but more personable things like racism, prejudice, the clique situation, drama. If you have any of those things and you have any specific questions that are more personal, you can hit me up with that and I will help you out as best as I can. Of course, if you feel like this video had value, make sure you like, comment, and subscribe, as well as comment below anything that you experience in your nurse residency or anything that you're going through. Let's all talk about it in the chat below.